So I'm Daniel Vela-Duarte, part of the social committee of LINNC Americas, LINNC Paris. I have the pleasure once again to interview Dr. Adam Arthur. We spoke to him last year in LINNC Paris. Miriam Vicente did that, and we spoke about the trials of middle meningeal embolization for chronic subdural hematoma treatment as adjuvant treatment for it. And this year we wanted to just talk about general concepts of what has happened almost a year after the results. So he does not need further introduction. He is the chair of neurosurgery of the neurosurgery department at the University of Tennessee, Sims Moffitt Clinic. He's a past president of the Society of Neurointerventional Surgery. And of course, needless to say, mentor to many residents, many fellows. And he has joined us on this educational venture once again to continue educating not only the U.S. trainees, but also the world trainees, if we can say that. One of the main questions I have for him is how have the results of the clinical trials, the STEM, Embolize, and the upcoming trials, how have they modified or basically changed your workflow, your strategies to treat patients pre or post-surgically in a big university institution like where you are?
That's a great question. I think it's a therapeutic change that deserves some recognition. So in terms of inspiring residents and fellows, liquid embolics became available to us in the 1970s. And we didn't realize that the network of the middle meningeal artery might have an impact on recurrence for subdurals until the last 5 to 10 years. So there are probably many other situations where inspired, thoughtful, creative therapies are possible. And so I think it's wonderful to notice this change in therapy. What I would say is that in our center, embolization of the middle meningeal artery with liquid embolics for chronic subdural has become a mainstay of treatment in patients with chronic subdural. And it didn't even exist in our center a little more than 10 years ago.
Right.
So it's a major change.
So based on these treatments and all the changes that you have done that you have basically adapted into your workflow in your institution, what are the challenges pre-surgically, post-surgically, and even ICU care for these patients in the next months, in the next year? Because from these answers, we can educate our community, we can educate other university centers, even community hospitals to continue adapting these strategies.
It's a great question. So I think we're still in a phase of learning and accumulating the data. So I'm very much looking forward to the combined analysis from several of the large clinical trials. Okay. But what I can say is we're dealing with a fragile population of older patients. And so, for instance, I think there are many of them who need antiplatelet or anticoagulation medications that now we're not stopping for as long as we used to, right? Which helps to lower the risk of morbidity and mortality related to concurrent conditions like atrial fibrillation or coronary stents. Another thing I'll say is I've begun to think about the treatment of chronic subdural in terms of two different kinds of treatment. One is a disruption of the microenvironment, and the other is alleviation of the mass effect. So for a given patient, you might imagine some of them just need the disruption and they don't need an immediate alleviation.
Correct.
For that patient, you might consider standalone embolization.
Okay, without draining.
Without drainage,
Mm-hmm.
which is a new concept that's being developed. And then another thing is we can, I believe, have more effectiveness with minimally invasive drainage solutions, like just a twist drill burr hole and JP drain type of solution, rather than in the past where we would do a microcraniotomy or 2 large burr holes with drainage because we were trying to both disrupt the microenvironment and alleviate the mass effect. So now we're seeing more patients in my center treated in the angio lab with a minimally invasive twist drill burr hole in conjunction with liquid embolization of the MMA through the same anesthetic procedure.
Do you observe those patients in the neuro ICU expect any improvement or to continue stable, and then see neurological changes to determine whether they go to drainage or if they go to a standalone treatment endovascularly?
Yeah, I do believe that patients that have significant neurologic deficits related to mass effect need to have the mass effect alleviated.
Or the thickness.
Right. I still think the patient exam is very, very important rather than going off an arbitrary number of things. But of course, we look at the imaging, we look at the deformation of the brain, we look at the midline shift.
Okay. And so, because we know that other strategies are still under analysis and continuous studying in other clinical trials, what's your take on, or your opinion on, the ongoing trials for particles and even for coils?
So I'll note that the M-Protect results, which was the only RCT to date for particles, were negative. Now, there seemed to be a trend towards effectiveness, and I do believe that particles can be effective. There's been no significant evidence with coils. I again believe probably there will be an effect. However, my opinion is that you can enhance effectiveness and lower risks through a very distal microcatheterization and a distal penetration with a liquid embolic. So in our center, that's still our preferred strategy.
This is obviously more of a personal curiosity as well, but we are going to include this answer hopefully as part of the LINNC, and maybe in the future versions of the LINNC. But we need to know what's the upcoming study of meningeal artery injection of lidocaine for headaches, for migraine.
Yeah, this is amazing, right? From my perspective, migraine affects millions, hundreds of millions of people in the world.
Imagine,
it's often young people. It's more often women than men. And some of them are well treated through existing modalities, but there's a significant portion that are not well treated. And I believe we've learned with chronic subdural that the inner layer of the dura has some unique vascular properties that I think are related pathophysiologic to chronic subdural, and there's no question they're related to migraine. Dr. Silberstein is a neurologist who spent his career studying migraine, likes to say that migraine is like hives that starts on the inside of the dura and can go from there into the brain and into the skin. So there's a lot that needs to be done. My center, in conjunction with Stony Brook, has just published our series with lidocaine. Adnan Qureshi and others have published lidocaine. As you know, Johnson & Johnson sponsoring a trial of embolization. We're hoping to enroll the first patient within the next 2 or 3 weeks.
Okay.
It's a feasibility study. There are many other investigators. So many more questions than answers. But what an exciting time to be in this field.
Yes, absolutely, no doubt. Well, Dr. Arthur, thank you very much for your time, for these enlightening conversation answers, and we hope to see you in Paris.
I'll see you there.
All right, thank you.